33-year-old gentleman. Let's see, he was first diagnosed with hepatitis C last year. He's not sure when his first exposure was or how he got it. He said sexual partner, he denies any drug use, but he was also in prison for 2 years, so I'm wondering if there's also exposure there. He doesn't smoke, he drinks socially. His overall exam was normal. His ultrasound showed unremarkable liver. I did get his HIV results is negative. His genotype is 1A. He has a history of hyperlipidemia, anxiety, chronic tension headaches. We did start him on vitamin D replacement, but no other medications. He is immune to hepatitis A and B. He weighs 243 pounds, BMI is 34. His labs overall were okay. His platelets is 301. His ALT was 63, AST is 39. His APRI was 0.3, child was 5A, and MELD score was 7. His iron counts were okay. His vitamin D was 31. Fibrosis was F0. And like I said, genotype was 1A. I'm pretty sure Maverick would be okay for this. I think everything else is okay.
Awesome. Thanks so much, Gary, as always. Before we jump into the recommendations, did anyone have any clarifying questions or comments about the case? And everyone's welcome to chime in.
I had one question. This is John. Hey, Gary, with the hepatitis B immunity, do we know if that was vaccination related or natural exposure? Was his, do you have if his core?
It was, give me 1 second. I do believe it was vaccine. Yeah, his core was negative. It was surface antibody.
Okay, cool. Thank you.
Thank you for that question, Dr. Gilfus. Any other questions, comments for Gary?
Hey, Gary, this is Rachel. I just wanted to clarify, you said he's not on any medications, but mentioned the hyperlipidemia. Any indication to treat that hyperlipidemia in the near future?
He right now is kind of resistant to any kind of medications. So
Okay.
we talked about a lot about lifestyle modifications and trying to change diet and increase exercise. It'll just repeatedly work on him as every time I see him.
Gotcha. I'm just curious just because of the statins and the interaction. So if he's not, you know, in the next 8 to 12 weeks, then no biggie.
All right.
Thank you, Rachel. And any feedback and further recommendations for Gary in this case? Everyone's welcome to chime in as well. Dr. Gilfus, I see you muted there.
Yeah, it's good. And by the way, nice to have a hepatologist on the call, by the way. We're always infectious disease heavy here. So if you have any comments on any of these cases from a hepatologist standpoint, please speak up. We can use it. You know, we hopefully we'll not have any advanced cirrhotics on today, but
yeah, that's the bummer, John, but that's okay. I may be of little use then.
Well, the good news is none of these people, at least this case, doesn't seem to have any advanced liver disease. We don't see any evidence of extrahepatic manifestations. His transmission mechanism he reports is you know, that's always a question mark, especially when it's been in prison. There's probably some higher risk stuff there. Gary, I got to ask, do you have any history of tattoos or you know, jailhouse tattoos or anything else?
He has no tattoos.
You said none?
None.
Wow, that's no medicines and no tattoos. This is a rare bird. So, yeah, you know, remember sexual transmission, you know, is very rare in the heterosexual sense, more so in MSM who are HIV positive. That's kind of the take home there. Doesn't matter, he has it, whatever. And so getting him treated, as long as he's not immune to, you said, I'm sorry, resistant to taking medicines for 2 months. You said he's resistant to taking hyperlipidemia therapies, but if you can convince him to take medications for 2 months, Maverick is logical. It's probably your shortest option. Remember, the only other 8-week treatment option that's available in general would be Harvoni, and he's not going to qualify because his viral load's too high. So remember, the 6 million count is your cutoff for short course Harvoni, and he's a little bit above that. There used to be a prohibition on using Harvoni short course with African American patients, but that's sort of been dropped off the prohibition of usage of short course Harvoni. Of course, you could use Epclusa for 12 as well, but if he's resistant to taking any medicines chronically, I think you're right on board with the Maverick. That's super logical. And I can't think of anything else to suggest on him. And he won't need any long-term HC screening or anything like that. So I think you're a good time to get him treated. Hopefully cross one problem off his problem list.
Thank you, Dr. Gilfus. Any other feedback or recommendations from anyone? And Gary, any other questions you had about your case that you wanted addressed?
No, everything was answered.
All right, awesome. Thank you so much as always.
Thank you.
We'll go on to the second case. So Amanda and Robin, anytime you ladies are ready, I will pull your case up and you know what to do. Just let me know when to scroll up or down. Thank you.
Hey guys, are you ready?
Yes, ma'am.
Okay. Our case is a 38-year-old male. He's was diagnosed in 2008. He's admitted that he started using marijuana and opiates at a younger age. Then he moved on to cocaine. He does have a past history of IV drug use, the usual heroin, dilaudid, meth, fentanyl. He was a recent OD in 2021. Since then, he's been in and out of inpatient rehab trying to get it together. He's currently inpatient now at Southern Highlands. When we did this, he wasn't. He was just a sub patient, but he's actually back in-house with them now. He is a current smoker, but doesn't use alcohol on a regular basis. And he plans to return back to doing maintenance and stuff after he completes his rehab program. He really doesn't have a whole lot going on. He's got history of depression, anxiety, acid reflux, and hepatitis. He doesn't, sometimes the medicine they had him on, he says he takes occasionally, but most of it's PRN for the anxiety part. His labs weren't really that out of whack. He is a genotype 1A. He complains of feeling tired sometimes, but he thinks that it's contributing to the hepatitis. He has been vaccinated and he weighs 191 pounds. His BMI is only 30.8. So other than him being younger, my choice is obviously Maverick because that's what I like. I guess that's what I like to use. Because of the genotype 1A, it's the easiest one for them to do and to take.
Excellent. Thank you so much. And if anyone needs to refer back to any of those labs or anything, let me know and I'm happy to pull up the case again. Any clarifying questions from the group? Feel free to unmute, raise hand, or chat in.
Hey, just a question. It's John. Was the association of fatigue with hepatitis from the patient or from you or from Google? I'm just curious.
No, he has complained at times. He's seen us several times in the clinic, and then when he was going to go upstate to do inpatient, I was coordinating with them. That ended up falling through. And when he came back in-house this time, it was prior to me writing this. He was just saying he was staying really tired lately. But I don't know if he was getting his medicine like he was supposed to up there. He looked pretty tired when he came back into us this last time. So I'm hoping that after I haven't seen him in several weeks after traveling. I'm hoping that now he's doing better and a little bit more stable back at in-house at Southern Highlands.
Cool. I like it when maybe we have something that'll make him feel better. We'll see. Don't want to promise him the world. He's obviously got a couple of reasons to feel weird. Hey, the only thing I couldn't catch real quick on the labs was the fibrosis score. Did you have an F score on that one? I saw a number, but I didn't see the F score. Maybe that's my bad.
Oh, Amanda, I think you were muted. I see you're speaking, but it's muted right now.
Sorry, it was 0.517 was Zachary score.
Oh, I'm sorry, serum fibrosis score.
Oh, that's on the last page. You can't see it. It's the
Right.
biomarker 0.67.
Yeah, that's a number. I was wondering what the F score was. I don't have those memorized. I'm assuming it's like a 1 or whatever, but each
He
test.
he wasn't a high class. I think he was a F0 to F1. I think that's the way it goes.
Thank you.
Amanda, how motivated is he for treatment? Is this something that he's really itching to get started?
Yes, because he actually went upstate, like I said, to Huntington to try to do in-house, like a long-term in-house. And somehow they didn't get coordinated with that. The people that I talked to acted like they were going to help him get into the sub program up there and have some kind of support for his substance abuse. When he got there, that kind of fell through. He has a sister in the area. She's an active user. So he actually chose to leave her, come back to Mercer County and go back into inpatient care to get treated. So for me, that was a big step for him. He didn't have to come back. He could have fell through the cracks and stayed in Huntington and us never have known it. So
How long is he going to be inpatient for?
it varies. They have programs from anywhere from 90 days up to a year.
Okay.
Right now, he's looking, unless the counts off, he's looking to 120 right now.
He's at 120 or that's where he's looking at? Okay.
Yeah, he should be 120 1st of November.
Okay. I guess my big thing would just be just to consider his access to treatment, and just making sure you have that plan in place to know where to dispense the medication to. If he leaves or transitions out, just he has to make sure he's communicating with you where he's going to be. It sounds like he is because he wants to, but if he does get admitted anywhere, he's got to bring a patient with him. They won't have it on formulary to dispense. And if he goes to a longer term rehab, he just has to know to make sure he brings it with him and communicates where he's transitioning to. But Maverick for 8 weeks is fine. I don't see, that's the shortest course. I think that would be, reasonable for him. He has, I guess the other thing I would say is, we have other options too with genotype 1A. Just as with the last case, there's also Epclusa times 12 weeks. There's Harvoni for 8 to 12 weeks. He wouldn't qualify for the shorter course of Harvoni only because, number one, it's not one of the preferred agents on his formulary, but his viral load is also over 6 million. So in terms of succinct course of treatment, it would be max for 8.
Yeah, and he has been coordinating, I guess, that his plan now is to stay in the area. So they have another step down that they go to. It's kind of like a monitored halfway house. So I think that's where he's headed after he finishes the program. As far as I know, last time I talked to him, that's what he wanted to do. So hopefully we won't have any problem getting his medicine to him. The nursing staff at Southern Highlands works really well with us. So
Beautiful. Thanks so much.
thank you.
Thank you, Kaylee, for that feedback. Any other comments from the group or recommendations?
The only thing that I'll add, and if you're going with Maverick, that's not a big deal, is it looks like he's got the omeprazole on the med list here. If for whatever reason you would have to use Epclusa, or if you would prefer to do that, and worried he's not going to be able to eat with the Maverick and want to do the Epclusa instead, is just to watch that omeprazole. The dose is okay. He'll just have to be educated to make sure that he takes the Epclusa with food and then separate that omeprazole 4 hours later.
Thank you so much, Rachel. Any other comments from the group? And Amanda, did you have any other questions about your case that you wanted to go over? No worries if not. You are still muted as well, but no worries. All righty. Well, thank you all so much for the cases and the recommendations as always. It's always such a pleasure being able to see you guys work so seamlessly to provide recommendations and all the great comments and questions. So thank you all so much. We are waiting for our third case presenter, so I'm not sure if they got caught up in clinic or anything, so we might have to reschedule them, which is totally fine, but wanted to give you all a heads up. So we can move into the didactic portion now. So Dr. Lammert, if anytime you're ready, I gave you the ability to screen share on your end. So I'll just turn things to you anytime you'd like to get started. Thank you so much.
Great, thank you. Let me share. Can you confirm that you can see my screen?
Yes, sir, we can.
Hey, again, I'm Craig Lammert. I'm a hepatologist at Indiana University. It's fun to look at some of these Hep C cases. A lot of our Hep C has actually been farmed out to our extenders, so we don't get to see a lot of Hep C in clinic anymore unless it's related to transplant or pending transplant. But I want to thank everyone for the opportunity to come and to reach out, at least in this regard, to extenders and primary care physicians about a disease that's really near and dear to me. Autoimmune hepatitis is a disease that I've chosen to study in kind of a niche-based approach in hepatology research here at Indiana University. And we are making incremental gains, but there's so much more to learn. So as I put together this didactic, I wanted to give at least enough details to help maybe some of the physicians in the room to better understand this disease, and maybe just to think about the approach with patients that they may see rarely in their clinic. And then also with a few touch points regarding HIV and HCV in the spirit of Project ECHO. Make sure that I can advance here. So with any didactic, maybe we'll just start with a brief case. This is a 56-year-old white female case that I often see, and kind of classically also in primary care clinic, I would assume as well. She's overweight and has diabetes for a number of years, blood pressure issues, but also hypothyroid as well. She was very aggressive with her weight loss because she paid close attention to what you mentioned to her last year, and she saw a significant improvement in her metabolic phenomenon. She was just complaining that fatigue has been more progressive over the past year. She's been doing otherwise okay without being in the hospital, but did have 2 urinary tract infections that she was treated subsequently with macrobid. Sleep's not great. She's still getting up multiple times throughout the night for frequent urination. So last year, when you looked at her test, her ALT and AST were mildly abnormal, about 1.2 to 1.3 times upper limit normal. The rest of her panel was generally okay, except for A1C, reminiscent of poorly controlled diabetes. The ultrasound that you completed showed increased echogenicity, and this seemed to be consistent with steatosis, which, as you're being the primary care doctor, you thought that this was kind of a done deal and worked with her with weight loss. And with that, her labs now actually show her ALT is still 76, AST 69, so slightly elevated. But the rest of the panel looks good, but she did see a significant improvement in her glucose control with a much lower A1C. So the aims for this talk, and we'll approach this case again, but I just want to provide some fodder of how you approach patients in the clinic that may have autoimmune hepatitis, but also other masquerading clinical illnesses as well. So provide some working knowledge, maybe talk about some strategic goals that we use in hepatology clinic and our approaches and how that relates to primary care, but also then to think a little bit more about autoimmune hepatitis phenotypes and maybe how we as a multidisciplinary group can really improve the overall outcomes and quality of life in patients with autoimmune disease, specifically autoimmune hepatitis as well. AIH is the classic prototypical autoimmune disease. It's female predominant, about 90%, has characteristic autoantibodies, the anti-neutrophil and anti-smooth muscle antibody in about 80% of patients, as well as genetic risk factors at the HLA called DRB10304. Outside of that, there's a combination of factors results in really failed immunostasis or immunologic homeostasis and results in significant T cell or lymphocytic driven inflammation within the hepatic lobule. The top slide there shows a normal liver architecture. The bottom side, you can see that what appears to be portal triads for the hepatic architecture are completely destroyed with infiltrating T cells, but also in the background, active B cells as well. Ultimately, we don't know what causes this, but it happens in all populations, all age ranges, and all ethnicities, despite being female predominant. And the presentations are variable, as are outcomes, treatment responses, and even the side effects that we see in clinic, which we'll talk a little bit more in depth. Just in terms of clinical presentation, about 2/3 of patients with this autoimmune liver disease can present insidiously. So they may not have any symptoms, or maybe they just have one or more non-specific complaints. About 1/3 of the patients will actually have developed cirrhosis at presentation. So we think that these patients probably fell under the radar in terms of routine health screening or any clinical symptoms that made them come to the doctor. So we think this probably contributes to a significant delay of diagnosis in these patients. But there is an acute severe presentation, which is a little bit scary. These patients can present with acute on chronic liver failure or acute severe autoimmune hepatitis where they present with significant jaundice and liver dysfunction as well. The way we diagnose this is not great. I'll be very honest with you. We have what are called the simplified criteria, which actually are a little antiquated. You can see that it depends heavily on the autoantibodies, as well as an IgG level that I often use in my clinic, as well as the real linchpin is liver biopsy. And obviously exclusion of other contributing factors. In this model, viral hepatitis needs to be excluded for points. At the end of the day, and you'll hear from me often, if you think autoimmune, I think you have to chase it in some regards. And we'll talk a little bit about the features that make me think a little bit more about autoimmune versus other conditions as well. We know that as a complex disease, this is particularly resultant of environment, but also genetic risks. We've alluded to that. And in fact, we've learned a little bit about some of the environmental contributions, and patients always want to know about this. There's actually been a few papers looking at stress and onset and relapse of disease, which I always find a little bit interesting. Medications, particularly macrobid or minocycline, are the poster children for drug-induced autoimmune hepatitis. So that's one mechanism. And then viral contributions. And again, HIV, Hep C have been two viruses of significant importance, but also things such as hepatitis B, CMV, Epstein-Barr virus, and even Parvo B19 have case reports of developing autoimmune hepatitis after significant infection. And then the genetic factors, again, with time, we hope we better understand, but outside the HLA, there are only two other genetic risk factors that have been identified in what are called genomic-wide association studies, but they all relate to the immune system and immune cell processing. So thinking about HIV, and again, the scope of the talk today, I think it's important and always worthwhile saying, in an old study from clinical gastroenterology from over now 12 years ago, that liver tests are often abnormal in patients with HIV. At baseline visit, at least in this cross-sectional study, about 20%, and even in a subsequent visit, some of those patients that were negative had follow-up positive results. So that's about 30% over the course of a year. I wanted to bring attention. I'm very interested in Occam's razor. And again, the idea that the most simplistic explanation is typically the right one. For John Hickam, who was a chairman of medicine here at Indiana University, also went to my alma mater for residency training, where he actually was coined this term, is really Occam's razor doesn't work always. And there's such a thing as Hickham's dictum, which is patients can have as many diseases as they damn well please. This is the case for other rare diseases, but also other diseases such as HIV as well. So when we look at those patients, we see a large percentage of them have other causes for abnormal liver tests. And this is NAFLD or fatty liver disease, but alcohol, obviously all the viral contributions, but unexplained in about 51%. Now, many of those patients are probably fatty liver, but also autoimmune hepatitis has been associated with HIV as well in the past. And actually, there's only about 30 to 35 cases of HIV patients in the literature with autoimmune hepatitis. But it's important to know that for most patients that are diagnosed with AIH, and this is a small study that looked at 13 patients, they presented with chronic persistent liver test elevation. These were also patients that were on heart therapy and actually had good viremic control as well. There was only a few that presented with jaundice or acute severe hepatitis with markedly abnormal liver tests. But also with these patients, we saw a lot of anti-neutrophil antibody positivity and elevated IgG, which again is another surrogate for autoimmunity. But the classic anti-smooth muscle antibody was only positive in 35%. So really highlighting the piece that often liver biopsy tends to be some of the crutch for diagnosis in patients that are a little bit more complex. Now, another group of patients that we all see commonly is fatty liver disease. And these autoantibodies that are really integral to the diagnosis of autoimmune hepatitis, particularly anti-neutrophil antibody and anti-smooth muscle antibody, can be positive in a very large percentage of patients with plain old fatty liver disease. So how in the world do we ever discern this? More to come on that, but the more concerning piece that we're seeing with autoimmune hepatitis patients is they actually have both. And in fact, here in Indiana, probably similar where you are, the ever-expanding waistline has increased the prevalence of not only hepatic steatosis, but fatty liver disease as well. So when we go back in time and look at a retrospective cohort of AIH patients from Vermont, and they do a very dedicated, expert-driven pathologic assessment of their liver biopsy, we find that actually steatosis is present on about 15% of the biopsies, and actual fatty liver disease causing hepatic inflammation or lobular inflammation is present about 15% as well, which is a concern. One of the reasons it's a concern because it changes the outcomes of these patients in some sense as well. Now, patients that had steatosis and AIH tended to be more overweight, Those with NASH also had diabetes, dyslipidemia, hypertension, the classic things that you would think of. However, the patients with NASH and AIH often presented with cirrhosis at presentation. So this is very important because this is actually a big predictor of poor outcomes in patients with autoimmune disease or autoimmune hepatitis as well. Outside of that, the biochemical response, which we'll talk slightly about in how we assess improvement in liver tests, they were similar, but the real take home from this was the patients that had both really had a significant risk for liver-related death over the long-term follow-up of these patients at Vermont as well. So again, as providers, myself as a hepatologist, I think even when diagnosing AIH and or NASH, we have to think about the other to provide the best level of care. This schematic here is really to highlight what's going on with this disease. I showed you the biopsy before, but what's happening? You're having liver cell destruction driven by lymphocytes, causing an elevated ALT, as well as IgG as a marker of B cell activity. And with that, we see potential risks of progression of, these are liver cores, with trichrome staining showing development of fibrosis over time. So this would be stage 1 or stage 0 or F1, all the way to stage 4 or cirrhosis. Now with treatment and strategies that we'll mention, we hope to improve this autoreactivity and really to restore some of this autoimmune balance, more homeostatic mechanisms. And this can be a number of different ways. But with typically corticosteroids as a first-line therapy, we see improvement, liver or the inflammatory cells leaving the liver, and improvement of liver cell architecture with the hopes that we actually see reduction in fibrosis. Now, the concern is only about 30 to 40% of patients may have improvement in fibrosis with good control. And particularly patients with cirrhosis at diagnosis typically don't see much improvement. It's kind of concreted in and the deal is set. So the way that we approach AIH patients initially is typically, first things off, I want to say there's no cookbook, but we have a few different strategies. And one of them is corticosteroids, so prednisone, or if you're in Europe, prednisolone. Budesonide is a new steroid that we've been using maybe over the past 5 or 6 years, which goes through extensive hepatic first pass metabolism. So when you swallow budesonide, it's essentially painting steroid on the liver. Then it's metabolized in the blood that leaves the liver that goes systemically, has no corticosteroids in it. So patients tend to like this better. The problem is budesonide probably doesn't work as well when liver tests are really markedly abnormal. We actually use these steroids as a bridge. Once we see improvement or rapid improvement of liver tests, we then start to think about adding steroid-sparing agents. And the list of medications that I use at my clinic is quite extensive. This is just a sampling of them. These are more common, but the real workhorse of this disease are the antimetabolites such as azathioprine and 6-mercaptopurine. Cellcept is also another one, or mycophenolate. Beyond that, in patients I see that are often hard to treat, we go out to other classes such as calcineurin inhibitors that include Prograf, cyclosporin, and even the mTOR inhibitors as well. This brief cartoon, I just wanted to show, this was a Delphi process that was done just recently by the members of the International Autoimmune Hepatitis Group, which I'm a part of, looking at how do we harmonize outcomes. So if we're treating patients, we want to see improvement in liver tests back to normal, because it turns out normalization of liver tests is one of the most important things that you can do for a patient with autoimmune hepatitis to prevent progression of fibrosis. So we do see about 15% of patients are intolerant to some of the therapies that we give. In the primary care realm, probably few per year, I cause diabetes by high dose corticosteroid usage. I also may propagate more fatty liver disease as well. Non-response is defined currently in the past year of about 50% reduction or not within 4 weeks of initiation of therapy. And then really the most important piece that seems to be coming out of literature, that looking at normalization within 6 months seems to be one of the most important pieces. And unfortunately, only 20% of patients, or 20% of patients don't hit this response criteria within 4 weeks, and half of them don't hit the 6-month endpoint. So again, concern, leaving these patients at risk for progression of fibrosis and having liver-related endpoints. The other really important piece is, unfortunately, in our world, corticosteroids are still leveraged a lot more than they probably should. And I think we lose sight of that. We did a cohort study online of an organization I run called the Autoimmune Hepatitis Association to try to understand steroid usage out there across the US. And what we found in percentage of patients, these are years after diagnosis of AIH, no matter what duration of disease, we're still seeing about 30% of patients requiring significant doses of prednisone or budesonide, which is a major concern. And just to put that in perspective, this is something I've changed in my practice over the past 8 years. When we think about low dose steroids that may help improve or continue to improve liver tests, or even improve other symptoms patients have, we see significant increased risk, even at very low doses of prednisone, for hospitalizations secondary to severe infections. So this is a very large study that was published in Annals of Internal Medicine a few years ago. And again, I think this clarified for us, this was in rheumatoid arthritis patients, that even 5 milligrams or even less increases the risk of hospitalization with severe infection. So I think from my perspective, I want to make it clear to everyone in the room that our therapies we use for this disease are by far adequate. And there's much interest in pursuing other strategies, and strategies that hopefully will also remove patients from prednisone or budesonide in the long term. So how do I prognosticate a patient? Again, patients can present at early age or late age. I think these are important. These are the first questions that patients ask me when they come in. There are some characteristics as we are learning about this disease, that younger onset disease, Black or Hispanic individuals, particularly of the male gender, with other things such as concurrent inflammatory bowel disease, not necessarily other autoimmune diseases, but cirrhosis at diagnosis, all tend to do worse over the long haul. Now, again, I say all, it's just an increased risk. And I think that's how, we must think about that as we prognosticate, particularly how aggressive I am with therapy in trying to hit clinical endpoints. Other things from the literature that have come up as significant: low vitamin D. This has been seen in other autoimmune diseases, such as inflammatory bowel disease. There are some autoantibodies that will send that are prognostic. Anti-soluble liver antigen is one that may portend to worse outcomes. And then finally, I told you treatment with incomplete normalization of liver tests within a year seems to be important. And we're getting some now evidence within the genetic realm. If anyone's been following, this is called PNPLA3. This is an important enzyme that's important in fatty liver disease, and one of the major risk factors genetically that we know relates to risk of fatty liver disease, but also fibrosis development, cirrhosis, and liver cancer development as well. So it's interesting that this plays a role, and this is in one paper. Outside of that, the lower risk patients, typically presenting older, female gender, those that have really quick, robust responses, no fibrosis or minimal fibrosis at diagnosis, and then drug-induced AIH. For some reason, we're able to withdraw therapy, and these patients just do better long-term. And there's one paper that actually shows loss of some of the autoantibodies, specifically the anti-smooth muscle antibody, after a year or two, again, portends to better outcomes. In terms of the traditional diagnostic and therapeutic model in AIH, we have disease pathogenesis. It develops, patient presents slowly with symptoms and onset. You diagnose it in a timely manner, and then you start treatment, you have a response. The problem is in autoimmune hepatitis, it typically looks more like this. And what I mean by this is once you get to treatment and response, we have other issues that get in the way. Patients can lose response. For some reason, their liver tests that normalized with prior exposure to immunosuppression no longer controls the disease. Therefore, going back and we have to rehash therapeutic strategies. They may have cumulative side effects of some of the medications that we use. And then on top of that, they may have disease progression despite we're hitting endpoints, but there are about 20 to 30% of patients that will still progress even though their liver tests are normal, which is surprising. They also, through time, can develop variant syndromes or other autoimmune diseases. And this is a good time to say that about 50 to 60% of patients with autoimmune hepatitis, if they don't at diagnosis, will develop an autoimmune condition, most commonly thyroid, but also things such as the Zika syndrome, scleroderma, Sjogren's. These are all incredibly important. And then obviously, much like any chronic disease, patients go through a multitude of symptoms throughout the course of diagnosis, treatment, and follow-up. But these also then involve things such as mental health, which all reduce quality of life and impact their social networking and structure. And then on top of that, stigma that comes along with having a liver disease, and a disease that has that dreaded H word in the title. The other symptoms we see, as I've highlighted, and this will resonate with this group, the fatigue had already been brought up with Hep C. We see it in a lot of liver diseases, cirrhosis and not, but moderate to severe fatigue will be reported in about 85% of patients with AIH throughout their disease course. A lot of this Also, beyond that will include poor sleep, itching. We see an increase in anxiety and depression, about 4 to 5 times that of healthy controls. And again, 20% of patients will report of these symptoms, and often untreated. And part of the reason, and again, this will be part of the main point of this talk, is patients get caught in between hepatologists and primary care doctors as the other thinks the other is doing the job for that patient. Other things, including joint pain and bone and hair changes, are what patients will complain about often as well. I just want to provide one paradigm as I kind of wrap up here about an approach to fatigue. Most hepatologists, I'll be honest, don't probably talk to patients about fatigue. However, there are other autoimmune liver diseases that fatigue also is an Achilles heel. So Dr. Jones in the UK about 5 or 6 years ago proposed an algorithm to address fatigue in the clinic. And again, it's a time-based issue. However, I think fatigue and symptoms of this disease should be approached much like you read an EKG. You have a very structured approach you take through it to make sure you're not missing anything major. But really what TRACE stands for is treating of symptoms and other autoimmune illnesses, other medical illnesses that contribute to fatigue. The A stands for trying to ameliorate problems associated with these other symptoms, such as sleep issues, depression, anxiety. Teaching the patient a little bit about coping with education, try to help them understand the importance of social interactions, and even conveying messaging about their disease, as well as how they maintain physical activity. And then, much like any good doctor, demonstrate some empathy. And overall, I think we can educate patients and set some better expectations that despite even if fatigue does not improve, there's a better grip and patients are better able to navigate it. So just moving through this with autoimmune hepatitis, and again, in the clinic, when you see these patients with really any autoimmune disease, I think you have to consider other autoimmune diseases. So this includes such as celiac or connective tissue disorders, screening for Zika, including dry mouth and dry eyes, because again, these are things that reduce quality of life, that may impact sleep, that may impact overall mental health as well. And then the common things that we think about in the nutritional things, but also anemia, thyroid disease, and then the joint pains that may be keeping them up at night or causing them significant reduction in their overall physical activity. Other medical conditions, again, as you know, all these things potentially can feed into fatigue. And again, I don't think that we all do a very good job at looking at this, but I'll advocate in that sense, really drilling into some of these things that we see associated with this disease. And one of the pieces that we recently saw in a qualitative study was doctors just were not talking to their patients about sleep. And so it goes as basic as sleep hygiene. And we all could benefit from this. But like in the case I told you, the patient was waking up still 2 to 3 times per night for urination. But also things that impact sleep is pain and itching and even restless legs that we see at a higher level in patients with autoimmune hepatitis as well. In terms of the coping, I work with patients to really try to take ownership of this disease. And I think it is kind of a nuanced approach. A lot of people talk about loss of identity, but again, I try to transcend that in some sense. And again, if you own the disease and you bring it to your ownership in your own home with your family, patients tend to do better in terms of navigating some of the side effect profiles. So we talk about other strategies such as pacing of activity. There's been a lot of talk about this and realizing that you just have to structure a week accordingly. If you're a shift worker, that may not work. And in fact, other data has shown that maintenance of some of these social structures and connections also can be very helpful. So I ask for patients to bring their family and friends to the clinic. I educate them. I also ask a number of my patients to consider counseling, particularly when I see relationships have already been strained by this disease, which is often founded in the sense that the husband thinks the wife is lazy, which is always surprising to me, but I guess I shouldn't be. The very final question I get is about exercise and diet. I think maintenance of muscle and bone strength is important. Diet, I never have a good answer because this hasn't been studied. But I think one of the things that we highlight is patients should be necessary or need to go to transplant should be able to. So again, we typically eat for heart health and other things. So I'm a big, strong advocate for Mediterranean diet beyond that maintenance of normal weight as well. And then finally, empathy. I want to emphasize this is not sympathy, but again, you can feel pity upon someone's misfortune, but really identify and understand and share that feeling with another, I think resonates well with this patient community. We need to be a group of willing and concerned physicians, and with that, then we can accurately kind of highlight our perception, but also the patient's perception of fatigue. And again, in our qualitative study that we looked at recently, some of these things highlight that primary care doctors are part of the problem. Patients had quoted saying, I have had these symptoms and the exhaustion, this pain that no doctor will address. Again, that sense that they are in between hepatologists and primary care doctors. And then stigma continues to be a surprise to me. And again, this idea that I'm so sick and tired of being treated like a drug addict. Well, unfortunately, a lot of those quotes came from patients that were getting this information from health allied staff at their primary care doctor's office or even clinics like mine. So I think we can just do a much better job. Let's return back to our case. And I think you would find that, again, this patient has metabolic risk factors, but concerningly, her liver tests had worsened over the course of the past year, despite significant weight loss and improvement of her diabetes. So I think that on top of hypothyroidism, as well as fatigue and as well as exposure to some medications that may increase the risk of autoimmune hepatitis, should sound the alarm that maybe a workup for autoimmune liver disease should be conducted. And that would be, first, collecting all the autoantibody profiles, which include the anti-smooth muscle antibody, the anti-neutrophil antibody, but also an IgG. I will also advocate sometimes an SPEP, looking at a gamma fraction can be helpful as another marker of inflammation. Sometimes the poor man's test that I highlight with patients is just total protein, may be a good marker of increased autoimmunity in patients that have ongoing autoimmune hepatitis as well. So when you consider beyond that, I think I highlighted most of these, particularly the negative workup and then again, the autoantibodies. What other testing would I do in considering this? All the autoimmune stuff that I highlighted before, thyroid, celiac, vitamin D I highlighted before too, that deficiencies related to worse outcome. One thing that is commonly not done is bone densitometry. I end up doing a lot of ordering for this in my clinic, and then I send it back to the primary care doctor. In any autoimmune liver disease, we see a tremendous amount of bone loss. And then some of these other markers are kind of options because they have been somewhat prognostic. Other screening questions that we should be doing in the clinic, really pinning down depression, anxiety, and fatigue. And I think if anything, in terms of ownership and following and tracking and looking for things to optimize, and then seeking the pieces that funnel into those that can make those worse, including itching, sleep, and joint complaints, and not being afraid to reach out to the rheumatologist, the hepatologist, the gastroenterologist that manages some of these other autoimmune conditions as well. So as I leave today, I just want to highlight again, this AIH is a rare, complex disease, but it has a real potential for prolonged delay. And again, that can impact patients' outcome with the development of more fibrosis with this disease. And again, being diagnosed late can really relate to increased liver outcomes. The disease side effects and medications that we use can definitely contribute to overall complexity, but it also can reduce quality of life. And again, better therapies are absolutely necessary. And I'm hopeful that, again, most primary care doctors are working with their hepatologists that are in control and trying to optimize some of this, particularly the patients that are on chronic long-term prednisone as a management strategy. And again, treatments are not perfect, but we can do much better. And again, this interaction between us outside the clinic, working together on behalf of the patient, I think ultimately results in better outcomes. And again, patients get really excited when we speak to their primary care doctors and everyone's on the same page. Part of my approach here at IU, I'm very much into education. When I started now 8 years ago, I launched a nonprofit just for the sole purpose of education because the education out there was pretty weak. We have slowly grown. And again, we now have an employee that's paid. We have a whole armament of a medical professional staff that helps us. But ultimately, we do education, but also we perform research here as well. So I just want to advocate for this. For patients that you see that have autoimmune hepatitis, there are resources online. And in fact, we host 6 different support groups across the US that are done virtually every quarter. So again, if you can just remember autoimmune hepatitis, there's an association for that. It's very easy to find via Google. So I just want to say thank you so much for allowing me to come in. And again, I'm always available for any questions or issues related to autoimmune liver disease, even outside autoimmune hepatitis in the future. But again, thank you so much for having me.
Thank you so much, Dr. Lammert. Wow, what a wonderful presentation.
Mm-hmm.
You really went above and beyond with incorporating that case as well, which we always so appreciate. And I will just say that in the recap emails we send out, we'll be attaching your slides there as well. So
Great.
everyone will be getting those wonderful resources and your great PowerPoint. So thank you. Really appreciate you.
Absolutely. Do you, again, Mithra, I see Carolyn Kidd has asked a
Yes.
question. Would you like me to answer any of these?
Absolutely, yes. And Carolyn, I see you unmuted as well. I didn't know if you wanted to maybe elaborate, ask your question, and I'll throw it to Dr. Lambert to maybe respond. Thank you.
Thanks. Number one, this was an absolutely awesome presentation. I really appreciated it as both a provider and also someone who lives with autoimmune hepatitis. My question for you is it all right? The way that I take care of anxiety, besides taking a prescription medication and for sleep help, is to occasionally smoke some pot. Is that okay?
Yeah, so this is a great question, and there's some other implications of this, Carolyn, specifically in states like mine where this is illegal, and how this relates to potential transplant in the future. I'll just speak from our perspective. We've become less and less concerned about marijuana use. However, we still have transplant hepatologists that like to see a negative result. Now, outside of that, we know that this is prolific. We know patients are using this as a treatment strategy. I'm going to include within the realm of marijuana use CBD. Now, that is huge here in Indiana, probably where you are as well. My concern only in regards to some of these things, I think those are strategies that are great. They're probably they're untested. CBD, we did a study recently about 3 or 4 years ago, and actually a variable amount of CBD doses have actually helped patients with AIH with a number of their extrahepatic manifestations. So I think marijuana is probably very similar to that. The problem is dosing. The other problem is there is a signal for high dose CBD in terms of drug-induced liver injury. Now, this came out of the studies. Now, we have CBD as a synthetic form to use for some pediatric seizure disorders, and there has been a DILI signal. So again, I think high dose is probably not preferred. Lower dose in terms of CBD, probably not unreasonable. And in fact, I've suggested to patients maybe even topical CBD therapies for joint pain, or even smaller doses of CBD for sleep. Marijuana, one of those things that I think when people tell me they use it, I collect the information, and you are not the first one to say that this is highly beneficial. But again, I think I put it in the perspective of, again, future of transplant. But again, if you're not in that window, it's probably not so important. And it's really interesting because some of these medications, and I'm not an expert when it comes to the cannabinoid pathway, but actually does integrate into the immune cell pathway as well through something called toll-like receptor 4. And there's some endocannabinoid receptors that actually go into the innate and adaptive immune pathways as well. So in fact, there is some hypothesis that treatment with cannabinoids may have some impact on autoimmunity. Now, again, not studied, but again, this is a shortcoming of our treatments or our clinical studies using these type of agents across the US. So I think as a strategy, I think once discussing with your doctor and kind of getting a, okay, that sounds good, this is a strategy you will employ. My other question though is what has been tried before that as well? Because I think there are things to consider. Again, that's a very deep topic as well. But again, sometimes at the end of the day, marijuana for some of my patients is all that has worked to solidify their sleep, control their anxiety, or and again, at the end of the day, it improves quality of life. The only study that comes close to this is a study in primary biliary cholangitis, so the sister disease. This is an autoimmune small bile duct disease. And dronabinol, which is a synthetic, which again is similar to THC, a single dose in the afternoon at 100 milligrams actually showed significant improvement of quality of life in terms of better sleep, less itch, and actually less fatigue, interestingly enough. So I think there's something to it. And so that's, hopefully that helps. I think, I do think we don't utilize our GI psych doctors as much as we should because the wait list is about 4 to 5 months long, at least here in Indianapolis. So it leaves a lot of patients to their own devices. Sorry, long-winded explanation, but again, a very important topic.
Yeah, thank you. Thank you.
And thank you, Carolyn, for that question as well.
Yeah, it's also been very uplifting as well. So thanks for that.
Excellent. My pleasure. And I will highlight too with this disease, you know, I think I always anticipate what the question is. Well, how many of these patients really require liver transplant? At IU, only about 5 to 7% of our total transplant population has autoimmune hepatitis. The problem is the patients that are transplanted tend to be the ones that are more aggressive. They're younger, right? They have problems. They've had years of corticosteroids. They have steroid side effects. So again, the disease is more than transplant. It's a quality of life pain, and that's one thing that we've tried to shift that dynamic a little bit more. And the issue is when you treat patients and they normalize their liver tests, they still are left with all the extra baggage, which again, I think is very hard for a lot of us providers to really compute because, and again, I make this joke in clinic. I pat myself on the back. I'm like, hey, your numbers look great. What else do you want from me? Well, there's a lot more you should want from me.
Mitra, you're on mute.
Thank you. I clicked right above the mute button. Thanks, Elizabeth. I was just saying thanks, Dr. Lammert, and asking if anyone else had any questions, comments. We have about 5 minutes left, so we can take our time. Alrighty, and if there are questions after the fact, as always, you can shoot us an email and we'll send it over to Dr. Lammert to have them addressed as soon as possible. The only announcement that I have is that the next session will be on November 10th and Dr. Feinberg will be presenting on PrEP. Again, thank you, big thank you to Dr. Lammert for joining us today. We really appreciate your time and sharing your expertise with the group, and it's just been such a pleasure to have you, so we appreciate it.
Thank you so much, all.
Thanks, everyone.
Thank you.
Take care. Bye.